Hello friends, in this video we will be discussing about some important respiratory disorders that you can get in neonates. So you can get a whole lot of case scenarios with with or without some chest x-ray findings, and you have to identify what the baby is suffering from. So very important for you to understand the pathophysiology of these various respiratory disorders and accordingly what would be the clinical presentation and the x-ray findings, right? So starting with a very important disorder from which often questions are asked, that is respiratory distress syndrome. Now this respiratory distress syndrome is also known as hyaline membrane disease, okay, or HMD. Now this hyaline membrane disease or respiratory distress syndrome is the most common cause of respiratory distress in a preterm neonate, okay. So it is much more common in preterm neonates, but it may sometimes happen in term neonates also, especially in infants of diabetic mother, okay, because they have a delayed maturation of surfactant. So the basic defect in respiratory distress syndrome is the lack of mature surfactant, okay. So the lack of adequate amounts of mature surfactant. Is the basic defect that is there, okay, in respiratory distress syndrome. So we need to know a little bit more about this surfactant and why is it important for us and what is the pathophysiology of respiratory distress syndrome, okay. Now starting with the composition of surfactant. One of the most important constituents of surfactant is DPPC, that is the dipalmitoyl phosphatidylcholine or lecithin, okay, phosphatidylcholine or lecithin. That is one of the most important constituents of surfactant, okay. Apart from that, there are some surfactant proteins. Types A, B, C and D, out of which surfactant protein type B is again the most important, okay, right. Apart from that, surfactant also contains cholesterol and cholesterol esters, cholesterol and its esters, okay, and it also contains phosphatidylglycerol. So these are the constituents of surfactant, and the function of surfactant is to decrease the surface tension of alveoli, okay, to decrease the surface tension of alveoli. In simple words, it means that what this surfactant does is, it forms a thin layer on the inner surface of alveoli, and it keeps the alveoli in a partially open state. It prevents it from collapsing completely. So during inspiration, we know the alveoli expand. During expiration, they sort of collapse, but this surfactant prevents them from collapsing completely, okay, because once they collapse completely, then it is very difficult to open them again. You need more pressure to do that, and a lot of respiratory problems can develop. So the surfactant, if it is present in adequate amount, mature surfactant helps in decreasing the surface tension of alveoli and helps it in keeping it in a partially open state, okay. Now this surfactant, it has been asked previously, very important, this surfactant is produced by type 2 alveolar cells or pneumocytes, okay, type 2 alveolar cells or pneumocytes, okay. And very important to know the timeline of production of surfactant. So the surfactant synthesis begins in the fetal lungs around 20 weeks of gestation. So at around 20 weeks gestation, the synthesis of surfactant begins in the fetal lung. But the surfactant begins to appear in the amniotic fluid only between 28 to 32 weeks gestation. While mature surfactant in adequate amount is present at or beyond 35 weeks of gestation only, right. So that is why you can make out more preterm the baby, more are the chances that mature surfactant is going to be deficient and the baby is going to land up in respiratory distress syndrome or hyaline membrane disease, okay. Now what is the pathophysiology of RDS? So you can see these are the normal alveoli in the open state with a lot of air inside them, okay. Now what happens in respiratory distress syndrome, we all know, is there is deficiency of mature surfactant. Okay. So because mature surfactant is deficient, what will happen? The alveoli are going to collapse. So like this, alveolar collapse. If alveoli will collapse, the space in between the alveoli are going to, edema fluid is going to collect there, and there is going to be inflammatory cells also which are coming, and they will cause diffuse alveolar damage. So there will be interstitial edema, diffuse alveolar damage, okay, alveolar wall damage will be there, and there will be fibrin deposition, right? And that is why in the lung biopsy, you can see this eosinophilic hyaline-like material. So on the lung biopsy, you can see this eosinophilic hyaline material, right, in respiratory distress syndrome. Okay. Now, what are the clinical features of RDS? So, the usual case scenario where we are going to suspect respiratory distress syndrome is a preterm neonate So, more preterm the baby, we know more the chance of RDS. So, a preterm neonate, especially those less than 35 weeks gestation, who presents with respiratory distress which may be mild, moderate or severe soon after birth with characteristic chest X-ray picture. Okay. Right. So, that is a typical case scenario in which we suspect respiratory distress syndrome. And what does this characteristic chest X-ray picture mean? Let us see. So, characteristic chest findings that you get in RDS is, so you know what is happening, that the alveoli are collapsing, right? The alveoli are collapsing. So, there is less air in the alveoli, right? So, because there is lesser air in the alveoli, you can get this ground glass haziness of the lungs. So, instead of the lungs appearing, black, they are going to appear grey. So, you get this ground glass haziness of the lungs, okay, ground glass haziness of lungs. But because there is no problem in the bronchus, bronchioles, there is still air in the bronchus and bronchioles, okay, there is no problem in the bronchus and bronchioles and there is air in them. So, you will get presence of something known as air bronchogram. So, like this you can get presence of black shadows in this ground glass opacity, which is presence of air bronchogram. So, like this, right. So, what we get here is, we said, so you get ground glass haziness of lungs, and because alveoli are not open properly, there is less air in the alveoli, you are getting ground glass haziness of lungs, plus because of collapse you can get crowding of ribs can be there, crowding of ribs because of the lung collapse can be there, okay, and you get presence of air bronchogram, okay, presence of air bronchogram. And sometimes what happens, some of the alveoli have surfactant, some do not. So, some are collapsed, some are open, some are partially open, some are partially closed. So, you can get reticulogranular or reticulonodular opacities as well. So, you can get reticulogranular or reticulonodular opacities, okay, right. So, these are the typical chest X-ray findings that we get in respiratory distress syndrome or hyaline membrane disease, okay. Now, how do you diagnose respiratory distress syndrome? So, we diagnose it, one, by the means of the typical clinical features or the case scenario, the chest X-ray findings that we already discussed, and there are also some ways by which we can detect the adequacy of surfactant, whether adequate surfactant is present or not. Antenatally, we can take out some amniotic fluid and we can run some tests on that and see whether there is adequate surfactant in the baby or not, right? We can get an idea about it, okay. So, let us see how. So, in the amniotic fluid, we can do something known as LS ratio or lecithin is to sphingomyelin ratio, okay. The lecithin is to sphingomyelin ratio we can do. And if this LS ratio is greater than equal to 2:1, then it indicates presence of mature surfactant. Okay. What else? We can do something known as shake test. What do you do in shake test? We take equal volumes of the amniotic fluid plus ethyl alcohol. So we take equal volumes of amniotic fluid plus ethyl alcohol in a test tube, and we shake it for some time and we let it stand for some time. So if you see one or more complete ring of bubbles on the surface of this, then that indicates mature surfactant. So presence of one or more complete ring of bubbles on the surface indicates presence of mature surfactant. Okay. What else? We can also do some other investigations that, like, we can do direct estimation of phosphatidylglycerol levels. Okay, phosphatidylglycerol levels. And we can also do one test which is called Nile blue sulfatase test. Has been asked in MCQs previously. Nile blue sulfatase test is used to detect skin maturity, brain maturity, lung maturity, GI maturity. So it is basically, the answer is lung maturity. So you can do Nile blue sulfatase test. So Nile blue sulfatase test can also be done to detect lung maturity, right? So these are the ways by which, using amniotic fluid, you can get an idea whether the baby has adequate amount of surfactant or not. Okay. Now, what is the management of RDS? So very important in the management of respiratory distress syndrome is supportive care. So if the baby is having hypoxia, you need to give oxygen supplementation. Okay. In mild cases, CPAP alone suffices. So oxygen supplementation, if a lot of distress is there, IV fluids, you admit the baby in a NICU, maintain normal temperature and maintain normal blood glucose of the baby. So if there is mild respiratory distress only, then CPAP or continuous positive airway pressure usually helps by keeping the alveoli in an open state. Okay, continuous positive airway pressure. So you get an idea about the severity of RDS using a score that is known as Silverman score. So we can do a Silverman scoring, and Silverman score greater than equal to 7 indicates severe respiratory distress. Okay. So Silverman scoring can be done in RDS cases. It is also known as Anderson-Silverman score. Okay. Now moderate to severe cases of RDS, require, in addition to CPAP, they also require intratracheal surfactant. So surfactant is to be injected directly into the trachea through an endotracheal tube. So intratracheal administration of surfactant is required in moderate to severe cases. Okay, and usually bovine surfactant or some synthetic surfactant is or taken from, so either you can take an animal product or you can take a recombinant surfactant, so that is to be used. Okay, so only in moderate to severe cases intratracheal surfactant is used, and previously what was followed was the ensure technique. What do you mean by ensure? So ensure means intubate, give surfactant, extubate, intubate, give surfactant, extubate. So depending on how much is the respiratory distress, if the baby does not have much distress, you just give intratracheal surfactant, extubate the baby, put the baby on CPAP. But if the respiratory distress is like really severe, you might have to start mechanical ventilation in severe cases. Okay. So severe cases you might have to put the baby on mechanical ventilation. So that is about the treatment of respiratory distress syndrome. Okay. Now moving ahead to the prevention of respiratory distress syndrome in neonates. To prevent respiratory distress syndrome, we use something known as antenatal corticosteroids. Okay, antenatal corticosteroids. So you can use either injection betamethasone or injection dexamethasone. So either injection betamethasone or injection dexamethasone can be used. Okay. Indication: it is to be given to all pregnant ladies expected to deliver between 24 to 34 weeks gestation. Contraindication, you will avoid giving surfactant if there is suspicion of clinical chorioamnionitis or any infection, then you avoid steroids. Okay. Which antenatal steroid to be used? We already mentioned we can use either injection betamethasone or injection dexamethasone. So injection betamethasone, and the doses also are many a times have been asked in the INI-CET pattern questions or even in your NEET PG pattern. So doses of antenatal steroid is important. Injection betamethasone, the dose is 12 mg intramuscularly, 2 doses 24 hours apart. Okay, 24 hours apart. So very easily you can remember 12 into 2 is equal to 24. So you are giving 12 mg, 2 doses 24 hours apart. Okay, easy to remember. Dexamethasone, again remember, each dose is half of the dose of betamethasone, but the total dose remains same, that is 24 mg. So injection dexamethasone, the dosage is 6 mg, 4 doses 12 hours apart. So again you are giving it total over 48 hours, and 6 mg 4 doses making it a total of 24 mg. Right? Now out of these two you can give any steroid. Now if a choice is given which one to prefer, so it has been seen that betamethasone has got lesser side effects and it gives better neuroprotection. Okay, so betamethasone has been seen to have slightly more neuroprotective effect than dexamethasone. Okay, so if available, this should be preferred. Slightly more neuroprotective effect and lesser side effects. While dexamethasone, it has been seen it is more cheaper and easily available. So that is why in the Indian National Program, what is recommended currently is dexamethasone. But you can use either of these. Okay, they have almost equal efficacy, right? But giving antenatal steroids is really important. Now, why is it important? What are the beneficial effects of antenatal steroids? So it has been seen that these antenatal steroids decrease the risk of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and overall neonatal mortality in preterm babies. And remember, but it does not decrease the risk of neonatal jaundice. So if you get a question that antenatal steroids decrease the risk of all of the following except, the answer is neonatal jaundice, and it has come previously in your NEET pattern questions. Okay. So these are the beneficial effects of antenatal steroids. Now moving on to a little bit about neonatal pulmonary alveolar proteinosis, which has a similar clinical picture like respiratory distress syndrome, but there are some differences, and this has come multiple times in your previous AIIMS pattern questions. Okay, so here the basic defect is usually in one of the surfactant proteins. So most commonly the basic defect in the surfactant protein B. Okay. So what is the function of the surfactant protein B? This is the surfactant. It helps in forming a thin layer of surfactant on the inner surface of alveoli. If surfactant protein B is not there, then even though the alveoli has the surfactant, but this surfactant is not able to form a thin layer on the inner surface, so this surfactant will not be able to act. So it is as good as not having surfactant. Okay. So if deficiency of surfactant protein B is there, then the surfactant is not able to act. So surfactant, even though it is present, but not able to act, right? So how will these babies present? So these babies are usually, it can be seen in even term babies. So term neonates, and this has a genetic basis, it runs in families. Okay, so term neonates with respiratory distress soon after birth, with family history of similar illness in a previous sibling, similar illness in a sibling who died. So this is a fatal condition for which till now no successful treatment is possible except for lung transplant, which is again rarely possible. So term neonate with respiratory distress soon after birth with family history of similar illness in a sibling who expired, with chest X-ray features like RDS, that means ground glass haziness of lungs and all, with lung biopsy findings similar to RDS, that means eosinophilic hyaline appearance. So this is a scenario where your diagnosis is going to be neonatal pulmonary alveolar proteinosis, right? So points favoring the diagnosis: term neonate, respiratory distress soon after birth, family history of similar illness in a sibling who expired. So this is a fatal condition. Chest X-ray features similar to RDS, lung biopsy features similar to RDS. So that is how the neonatal pulmonary alveolar proteinosis is going to typically present. Okay. Now, moving ahead to a little bit about meconium aspiration syndrome. But before that, you need to know what is a meconium. So meconium basically is the first stool passed by the baby. First stool passed by the neonate, and it is usually greenish black in color. Okay. What is the composition of meconium? What all things are present inside meconium? Okay, what is meconium comprised of? So meconium is basically comprised of bile, mucus, lanugo, that is the hairs present on the body of the baby, okay, denuded intestinal epithelial cells, okay, denuded intestinal epithelial cells, amniotic fluid, and water. So you can appreciate that meconium is a sterile substance, okay. Meconium is a sterile substance. It does not contain any microorganisms like the stool of older children and adults, which contains coliform bacteria and other organisms, okay. So meconium is a sterile substance. Now what is the problem that happens once the meconium enters the airways and the lungs? Let us see. So the pathophysiology of meconium aspiration syndrome. Now what happens is, most commonly what happens is, this air, the meconium plug is formed inside the bronchus and bronchioles, the large airways, and such that air is able to enter the lungs, but it is not able to go out. A trap valve like mechanism forms, leading to, collection, hyperinflation of the lungs, excessive air inside the lungs, leading to overexpansion or hyperinflation of lungs. So obstructive emphysema is what is most commonly seen. So most commonly you see obstructive emphysema because the meconium plug obstructs the larger airways, partially creating a trap valve like mechanism such that the air is able to go inside the lungs, but air is not able to come out of it, right? So most commonly obstructive emphysema is seen, as a result of which there is hyperinflation of lungs, okay? Hyperinflated lungs. Right? What else? Now apart from that, because meconium is a sterile substance, but there are a lot of chemicals like bile salts, amniotic fluid, mucus, and so a lot of things are there in the meconium, so that can cause irritation of the alveolar lining, and you can get chemical pneumonitis. So so heterogeneous pulmonary infiltrates can be there, chemical pneumonitis. Plus, what happens, this meconium sometimes can block the smaller airways completely, leading to collapse of that segment of the lung. So there can be segmental collapse or atelectasis. So complete, blockage of the smaller airways can give rise to segmental collapse or atelectasis. So segmental collapse or atelectasis can be seen. So that is the pathophysiology that happens in meconium aspiration syndrome. Now, once we have understood the pathophysiology, the chest X-ray findings are very, very easy to understand, right? So first, what is a typical case scenario in which you are going to suspect meconium aspiration syndrome? So we will suspect this in a term baby. So a term neonate who is SGA. So the baby is small for gestational age, or the baby is having IUGR. Okay. In those babies, the risk of meconium aspiration syndrome is more, okay. Born through meconium stained liquor. So there is a history of the liquor being meconium stained, okay. Presenting with respiratory distress soon after birth. Respiratory distress soon after birth, with increased anteroposterior diameter of the chest. So we said that lungs are hyperinflated in meconium aspiration syndrome. So the anteroposterior diameter of the chest of the baby will appear to be increased, okay. So with increased anteroposterior diameter of chest, with typical chest X-ray findings, which may or may not be mentioned. So that is a typical case scenario where you suspect meconium aspiration syndrome. So we said that A term neonate who is SG or IUGR, born through meconium stained liquor, presenting with respiratory distress soon after birth, increased AP diameter of the chest indicating hyperinflation, and the typical chest X-ray findings may or may not be present, right? So that is where you suspect meconium aspiration syndrome. Now, what are the typical chest X-ray findings that we are mentioning? So one is, we said that there is going to be obstructive emphysema, right? Hyperinflation of lungs. So what will happen? Flattening of the domes of diaphragm. Okay, the domes of diaphragm are going to push down due to excessive air, and because there is excessive air in the lungs will appear to be more black. Unlike what happened in respiratory distress syndrome, where lesser air was there in the lungs, so lungs appeared more white, right? Ground glass opacity of lungs was there. So here you will get hyperinflated lungs. And how will you identify hyperinflation? So one is, there will be flattening of domes of diaphragm, and increased radiolucency of the lungs. Okay, so lungs will appear more black. Increased radiolucency of lungs. So hyperinflated lungs will be there. What else? We said there can be chemical pneumonitis. So there can be heterogeneous pulmonary infiltrates. So heterogeneous pulmonary infiltrates can be there because of the chemical pneumonitis part, right? What else? You can get segmental collapse or atelectasis. So segmental collapse can be there. So there can be, opacity with a sharp border. Segmental collapse or atelectasis can be there. So these are the chest X-ray findings that you can get in meconium aspiration syndrome. Okay, right. Now, what is the treatment of meconium aspiration syndrome? So the treatment of meconium aspiration syndrome is mainly supportive. Okay, so it is mainly supportive. So if the baby is having hypoxia, then you need to give oxygen. If the baby is having severe respiratory distress, you might even need to intubate the baby and start the baby on mechanical ventilation, right? Now, in severe cases, there are some treatment options available. What are they? Let us see. So in severe cases, there has been some improvement with intratracheal surfactant, though the mechanism is not very clear. But intratracheal surfactant has been seen to produce some improvement in severe cases of meconium aspiration syndrome. Inhaled nitric oxide therapy also has seen to be produced some results. Okay, then you can use high frequency oscillatory ventilation. So there's something called high frequency ventilation that can be used, and in very severe cases even ECMO, that is extracorporeal membrane oxygenation, may be used. So extracorporeal membrane oxygenation may be used, right? So that is about the management of meconium aspiration syndrome, another very, very important disorder about which you must know. Okay. What are the complications of meconium aspiration syndrome? So meconium aspiration syndrome can predispose to pneumothorax because there is hyperinflated lungs, okay, and the alveoli may give away and produce pneumothorax, and there are also chances of having PPHN or persistent pulmonary hypertension of newborn. So persistent pulmonary hypertension of newborn or PPHN can also be seen, right? Now moving ahead to transient tachypnea of newborn. So this transient tachypnea of newborn is one of the most common causes of respiratory distress in a term neonate. So in preterm neonate we said RDS is very, very common, while in term neonates it is TTNB is one of the most common cause of respiratory distress. Okay. Transient tachypnea of newborn. The basic defect here is delayed clearance of lung fluid. So in the fetal life the lungs are totally collapsed and filled with fluid. As soon as the baby is born, the baby takes his first breath and the lungs open up and there is clearance of the lung fluid. So if there is delayed clearance of lung fluid, then you get TTNB. So because it is due to delayed clearance of lung fluid, it is also known as delayed adaptation. And it has been seen that delivery by caesarean section is a very important risk factor for TTNB. Because once the baby is having normal vaginal delivery, there is some squeezing force on the chest of the baby which helps in the clearing off of the lung fluid. If you bypass that and the baby is born by caesarean section, those babies are seen to have more chances of TTNB. So delivery by caesarean section is a risk factor. Okay. Clinical features. So what you get here is usually a term baby So what you get here is usually a term baby born by cesarean section, who developed mild respiratory distress immediately after birth, which resolves spontaneously in 48 to 72 hours. And the typical X-ray findings may or may not be present, right? So that is a typical case scenario where you suspect TTNB. So what are the pointers to the diagnosis here? So it is a term baby born by cesarean section with a risk factor for TTNB, with respiratory distress soon after birth, which resolved spontaneously in 48 to 72 hours. So this is, the name itself is telling you it is a transient tachypnea of newborn. So it is a transient condition which improves spontaneously, okay? The chest X-ray findings in TTNB, so you are going to have wet lungs, है ना? So there's more lung fluid there. So you can get this fluid in interlobar fissure, okay? So there can be fluid in interlobar fissure. There can be pleural effusion. And because of the, lung fluid, you can get prominence around the hilum. So perihilar streaky opacities can be there. So you can get perihilar streaking. Right? So these are the typical chest X-ray findings that you get in TTNB or transient tachypnea of newborn. What about the treatment of TTNB? So we already mentioned it is a transient condition. So usually it is a mild and self-limiting condition. Usually mild and self-limiting condition. Okay, and no treatment is required. And usually no treatment is required. So distress usually resolves spontaneously. You just need to monitor the baby, okay? So distress usually resolves spontaneously in 48 to 72 hours, right? So that is about TTNB. So moving on to another respiratory disorder in newborns, that is neonatal apnea. The definition of neonatal apnea is very, very important. So apnea means not breathing, okay? So neonatal apnea refers to cessation of breathing. So cessation of breathing for at least 20 seconds, okay? Cessation of breathing for at least 20 seconds or for any duration in the presence of either bradycardia or cyanosis, okay, either bradycardia or cyanosis in a neonate. So that is the definition of neonatal apnea, very, very important. So we know apnea means not breathing, okay, so it is cessation of breathing. For how long? For at least 20 seconds, okay, if there is nothing else, only cessation of breathing is there. But if it is accompanied by either, so neonatal apnea, if it is accompanied by either bradycardia or cyanosis, then any duration cessation of breathing is apnea. So if A is accompanied with either B or C, then any duration if it is called neonatal apnea. And if A is there alone, that means cessation of breathing is there alone, then you need it to be present for at least 20 seconds to call it neonatal apnea, okay. So very important. That is the definition of neonatal apnea, okay. Now, what are the etiology or underlying possible causes of neonatal apnea? So this neonatal apnea can be due to n number of causes. So it can be commonly due to neonatal sepsis or infection. Then some hypos can cause it, like neonatal hypothermia, neonatal hypoglycemia, okay, neonatal hypocalcemia, okay. Some things can cause it if they increase, like if neonatal jaundice, neonatal hyperbilirubinemia or polycythemia. So neonatal hyperbilirubinemia, polycythemia, okay, and NEC or necrotizing enterocolitis can cause it. If you are not able to find any other cause for apnea in a preterm neonate, but the baby is having recurrent apneas again and again, you think of a condition that is known as apnea of prematurity. So remember, this apnea of prematurity basically is a diagnosis of exclusion. So in a preterm neonate who is having apnea, if you check and see the sepsis screen is fine, there is no hypothermia, no hypoglycemia, calcium levels are normal, bilirubin levels are normal, hematocrit is normal, no features of NEC, still the baby is having apnea, then you call it apnea of prematurity. So it is basically a diagnosis of exclusion. A diagnosis of exclusion. Okay. And it is basically due to CNS immaturity. Due to CNS immaturity. Right? And more preterm the neonate, more are the chances of apnea of prematurity. Right? Now, neonatal hypocalcemia, we said, can give rise to apnea. Right? So, when do you call it hypocalcemia in neonates? So, we call it hypocalcemia when in a term neonate, the total calcium is less than 8 mg per dl or ionized calcium is less than 1.2 millimoles per liter. While in a preterm neonate, we call it hypocalcemia when the total calcium is less than 7 and ionized calcium is less than 1 millimole per liter. When do you call it polycythemia in neonates? We call it polycythemia when the hemoglobin level is more than 22 gram per dl or the hematocrit is more than 65% in a neonate. Okay. And whenever you are getting this, first thing is you rule out dehydration. So, dehydration can sometimes give rise to a raised hematocrit. So, rule out dehydration, give a fluid challenge and see in asymptomatic babies. But if the baby is symptomatic or the hematocrit levels are like really high, you might have to go in for a partial exchange transfusion where you remove some volume of the blood of the baby and replace it with the same volume of normal saline. Okay. So, the treatment of neonatal apnea is, one is of course respiratory support. Okay, respiratory support. So, you can give it either by CPAP, continuous positive airway pressure, or if there are severe life-threatening apneas, then you might have to use mechanical ventilation and look for the cause and treat it. We know the treatment of almost all the causes that we discussed, so look for the cause and treat it. Right? So, what are the treatments? So, we know neonatal sepsis, if it is there, what do you need to do? You have to give IV antibiotics, right? If there is neonatal hypoglycemia, what do you do? So, you give IV 10% dextrose, right? IV 10% dextrose. If there is neonatal hypothermia, what do? You warm up the baby using a radiant warmer. Okay, warm up the baby using a radiant warmer or incubator. If there is a neonatal hypocalcemia, you need to treat it with IV calcium gluconate. Okay, IV calcium gluconate, right? For jaundice, you need to treat with phototherapy and or exchange transfusion. Okay, phototherapy plus minus exchange transfusion, right? If there is symptomatic polycythemia, then you need to treat it with partial exchange transfusion. Okay, partial exchange transfusion with normal saline as we mentioned. If there is necrotizing enterocolitis, you keep the baby NPO, okay, and you start IV fluids, start IV antibiotics, and if required, in severe cases, surgery may also be required and total parenteral nutrition may be required. Now, what about the treatment of apnea of prematurity? So, for the treatment of apnea of prematurity, the drug of choice is injection caffeine citrate. Previously, injection caffeine was not available in India, but now it is available. So, injection caffeine citrate is the drug of choice. If that is not available, then injection aminophylline may be used. Okay, right? So, that is about the management of neonatal apnea. Now, moving on to a little bit about bronchopulmonary dysplasia. This bronchopulmonary dysplasia is also known as CLD in neonates, that is chronic lung disease. Okay, chronic lung disease, and it most commonly affects babies born at less than 28 weeks gestation. That means very preterm babies and with birth weight less than 1000 grams. And it is basically due to various kinds of trauma to the lung. So, it is due to atelectotrauma, volutrauma by giving excessive volumes, barotrauma due to excessive pressures, okay, barotrauma, and free radical injury to the lungs. So, the oxygen, giving excessive oxygen can cause free radical injury to the lungs. So, free radical injury to lungs. right? Now definition of BPD. So there is a definition. BPD is defined for babies born at less than 32 weeks gestation, okay, who require oxygen for at least first 28 days of life, okay, for at least first 28 days of life. So it is for, definition for babies born at less than 32 weeks gestation who require oxygen at least for first 28 days of life, and they are assessed at 36 weeks of postmenstrual age. So they are assessed at 36 weeks of postmenstrual age. Postmenstrual age means their gestational age at which they were born plus the postnatal age. That means, suppose a baby was born at gestational age of 30 weeks and is 4 weeks old now. So the postmenstrual age will be 30 plus 4, that is 34 weeks from the LMP of the mother, right? Now, mild BPD. Mild BPD means a baby who was born at less than 32 weeks gestation required oxygen therapy for at least first 28 days of life, but now at 36 weeks of postmenstrual age, no supplemental oxygen is required. Okay, no supplemental oxygen is required. Then that is a case of mild BPD. Okay. Moderate BPD, if at 36 weeks postmenstrual age also oxygen required at FiO2 less than 30%, fractional inspiratory oxygen less than 30%. And severe BPD where oxygen required at more than 30% or there is requirement of CPAP or mechanical ventilation. And on X-ray you can see cystic shadows in the lungs of these babies. Okay, heterogeneous opacities can also be there. So that is bronchopulmonary dysplasia or BPD, defined for babies born at less than 32 weeks gestation who receive oxygen at least first 28 days of life, assessed at 36 weeks post-menstrual age. Mild BPD, no supplemental oxygen is required. Moderate, oxygen required less than 30% FiO2. Severe, more than 30% or CPAP or mechanical ventilation. Okay. Now moving on to a little bit about congenital diaphragmatic hernia. What is CDH? So CDH, as the name itself is telling you, congenital diaphragmatic hernia. So it is a defect in the diaphragm. So it is a diaphragmatic defect through which abdominal contents may herniate into the thorax. Abdominal contents may herniate into thorax. Okay, or rather it is associated with varying degrees of. So a diaphragmatic defect through which abdominal contents may herniate into the thorax plus varying degrees of pulmonary hypoplasia and intestinal malrotation are present. Pulmonary hypoplasia and intestinal malrotation. Okay, intestinal malrotation, right? So that is the definition of CDH or congenital diaphragmatic hernia. Diaphragmatic defect through which abdominal contents may herniate into the thorax and varying degrees of pulmonary hypoplasia and intestinal malrotation or obstruction is present. Okay. Other defects commonly associated with CDH which may or may not be present, of course, are esophageal atresia, omphalocele, okay, omphalocele where a midline defect is there and umbilical herniation is there of the bowel loops through the umbilical cord. So omphalocele, but this is covered by a membrane, unlike gastroschisis where it is open, not covered by a membrane. Okay, so esophageal atresia, omphalocele, congenital heart diseases can be present, congenital heart diseases, and CDH is also associated with trisomy 13 or 18, that is Patau or Edwards syndrome. Okay, trisomy 13 or 18. So these are other defects which may be commonly associated with congenital diaphragmatic hernia, right? Most common type of CDH seen in neonates, of course, is the posterolateral or Bogdalek variety. Okay, posterolateral, or also it is also known as Bogdalek variety. Bogdalek variety. Most commonly seen on left side. Okay, left side much more common than right side, and it is more commonly seen in males. Okay, though it may happen in females as well. The clinical features of congenital diaphragmatic hernia, it may sometimes present at birth and sometimes later in life. So at birth, if it presents with a triad of respiratory distress, okay, mediastinal shift, and scaphoid abdomen. So what happens basically is, through the diaphragmatic defect, the abdominal contents move into the thorax. So abdomen is scaphoid or scooped out appearance, and because the abdominal contents have moved to the thorax, the mediastinal shift is there and lungs are not getting space to expand properly. So respiratory distress, mediastinal shift and scaphoid abdomen. Okay. While sometimes if the diaphragmatic defect is not so severe, these neonates may remain asymptomatic in the neonatal period or infancy, and later in life, because of the intestinal malrotation part, they may present with intestinal obstruction. Okay, they may present with intestinal obstruction later in life. Right? Now, how do you diagnose CDH? So, diagnosis of CDH, one is by the triad of clinical features that we already mentioned. Another is it can be picked up on an antenatal ultrasound. The CDH is significant in size. Then a level 2 ultrasound is usually good enough to pick it up. So antenatal ultrasound can usually pick up congenital diaphragmatic hernia. Now after the baby is born, then a chest X-ray is done to confirm the diagnosis. So chest X-ray will show what all it will show. So it will show that there is a diaphragmatic defect. So there is a defect in the diaphragm through which the bowel loops can herniate into the thorax. So you will see the bowel gas shadows in the thorax like this. Okay, and you will see the mediastinal shift. The heart is shifted to opposite side and lungs are not getting space to expand properly. So pulmonary hypoplasia. So the border of diaphragm you can see is not very clear, right? So you can see that. So on chest X-ray, the diaphragmatic border not clear, bowel gas shadows in thorax, like you see here, the diaphragm outline not clear on that side, where the bowel gas shadows are there, and there is mediastinal shift and evidence of pulmonary hypoplasia. So, CCAM or congenital cystic adenomatoid malformation is a close differential diagnosis of this condition. But in CCAM, you will be able to appreciate the diaphragmatic outline properly because there is no diaphragmatic defect as such. Okay. Now, medical management of CDH. A baby with known or suspected CDH. Known means on antenatal ultrasound you already have the diagnosis. Suspected means the baby is born and you have the triad of respiratory distress, scaphoid abdomen and mediastinal shift. Then remember, the first thing to remember, we all know that bag and mask ventilation is contraindicated. So you are not going to do bag and mask ventilation for the resuscitation of these babies, right? So what will you do? If the baby is having severe respiratory distress. So previously CDH was thought to be a surgical emergency, but now it is understood that the medical stabilization of the baby is first more important. So you have to do that. So it is a medical emergency as well. So if the baby is having severe respiratory distress, you are not going to do bag and mask ventilation, then what are you supposed to do? So you have to do endotracheal intubation. So if the baby has been intubated properly, then it is fine. You insert a nasogastric tube. So endotracheal tube is in trachea. So you are sure about that. Then what will you do? You insert a nasogastric tube as well, so that the stomach and bowel loops get decompressed. So insert a nasogastric tube. Do a chest X-ray to confirm the diagnosis, and surgery if indicated. Right? Okay. But if you have done an endotracheal intubation and you are suspecting that your endotracheal tube has gone in the esophagus instead of trachea. So if your endotracheal intubation has been done and suspicion of endotracheal tube in esophagus. So instead of trachea, if your endotracheal tube has gone into the esophagus, what will happen? So when you start, doing bag and tube ventilation, what will happen if your endotracheal tube is in esophagus? Then instead of improving, the baby's condition is going to worsen and there will be further mediastinal shift, right? If that is there, if suspicion of endotracheal tube is in esophagus, then what should you do? So you have to first confirm the position of ET, and we know what are the ways to confirm. So you will auscultate and hear bowels, breath sounds are audible on both sides or not, chest rises there or not. You can use the ET CO2, end tidal carbon dioxide, to know, okay? So confirm the position of endotracheal tube, and that should not be done by a chest x-ray. You can do it by a ETCO2 or by other methods that we have already discussed in the video on neonatal resuscitation. So confirm the position of endotracheal tube but not by a chest x-ray. Okay, if that you're done with it, but still you are unsure about it, then you can remove the endotracheal tube and re-intubate. Okay. What else can you do? You can insert a nasogastric tube to decompress the abdomen. And finally, you have to do a chest x-ray to confirm the diagnosis and surgery if indicated, right? So that is how you manage these babies. And if there is no severe respiratory distress and all, then straight away you insert a nasogastric tube and do a chest x-ray to confirm the diagnosis and surgery if indicated. So that is the medical management of congenital diaphragmatic hernia. So if there is a severe respiratory distress, do not do bag and mask ventilation, intubate the baby. If you are suspecting that intubation is not correct, then confirm the position using ETCO2 or other modalities. Remove ET and re-intubate if you are unsure. Insert a nasogastric tube. Finally, do a chest x-ray to confirm the diagnosis and surgery if indicated, right? So bag and mask ventilation, as we already mentioned, very, very important, is contraindicated and should not be done in congenital diaphragmatic hernia, because the condition of the baby will further worsen instead of improving. So what will happen if you do a bag and mask ventilation in CDH? So the mask is covering both the mouth and nose of the baby. So the air that you are going to give to the baby is going to go both through the trachea and the esophagus. The air that is going to trachea is fine, but the air that is going to esophagus will further go and distend the bowel loops and stomach, and there will be further mediastinal shift. And further the lungs will get lesser space to expand. So if you are doing a bag and mask ventilation, instead of improving, the condition of the baby may worsen. So bag and mask ventilation is absolutely contraindicated. Absolutely contraindicated in CDH. Okay, if a known or suspected case of CDH, do not do bag and mask ventilation. Okay, the most common cause of mortality in CDH is pulmonary hypoplasia or pulmonary complications. So there is a hypoplasia of lungs. So pulmonary hypoplasia or pulmonary complications are the most common cause of death in a child with congenital diaphragmatic hernia, right? What are the predictors of poor outcome in congenital diaphragmatic hernia? So there are some predictors of poor outcome in congenital diaphragmatic hernia. They are, if the pulmonary hypoplasia is like very significant. Okay, so if the lung head ratio, LHR, or the lung head ratio, LHR, is less than 1, indicating severe pulmonary hypoplasia. Okay, that is a predictor of poor prognosis. If any major malformation is there, any major malformation is associated, then that also is an indicator of poor prognosis. So any major malformation associated. If the defect is so severe that liver has herniated into the thorax, that also has a very poor prognosis. So herniation of liver into thorax has a poor prognosis. If the baby is so sick that the symptoms have begun in the first 24 hours of life, again poor prognosis. So symptoms appear in first 24 hours of life. First 24 hours of life, poor prognosis. And if the baby's respiratory distress is so severe that there is a need for ECMO or extracorporeal membrane oxygenation, then that is also a predictor of poor outcome in a baby with congenital diaphragmatic hernia. Okay. So these are some very, very important respiratory disorders, various case scenarios, their pathophysiologies. We need to understand them, and we need to understand the chest X-ray findings that we are getting. We need to identify these disorders and manage accordingly. So these are very, very important for your exams, and I'm sure if you go through this video, if you've gone through this video, your concepts would be crystal clear and you will be able to diagnose and make out what are the investigations to be done, what is the case scenario, how do you manage such a situation, and you will be able to answer all the questions that you get from this area. Okay, so happy learning.